Hi, I'm Scott Steele, the chair of colorectal surgery at the Cleveland Clinic, and thank you so much for allowing me to participate in this virtual event. I'm going to talk a little bit about emergency surgical disease, especially as it relates to infectious or inflammatory colitis. When you talk about dealing with the colon in emergent settings, and specifically with infectious and inflammatory settings, you have to say to yourself, here's the issues. First of all, saving the colon. Is it feasible? In this case, when you're getting pneumatosis and tachycardia and fevers and significant peritonitis, it's a no-brainer. But in other cases, that might be kind of a mixture. The patient might be, quote unquote, too sick to take the operating room, although that's a lot of whole lecture in and of itself. So ask yourself first, is saving the colon feasible? Second, if you remove the colon, are the outcomes overall improved? Or is there a non-operative therapy or medical therapy that the patient would do better with? Finally, is there a downside to doing it? If somebody cannot tolerate surgery or you cross a bridge too early in the game, then could have had an organ sparing approach, then potentially this would be something that you're not really willing to go down that road. And finally, what is the future? So first you have to say to yourself, what is that patient in front of you? Is this an acute change? Have they had it before? Is this a chronic condition that you're dealing with? You know, somebody who has chronic C. diff, who is a carrier, is much different than fulminant toxic colitis from C. diff. Think about it like that. Is it their first episode? Is it recurrence? Have you tried a lot of the different things in your armamentarium, or are you at your wit's end? And how does that play into the role of surgery? You know, you also need to ask them, are you immunosuppressed? An organ transplant? Are you on blood thinners? Is this a change? Was there any camping that was going on? You start to think of all the different things that we remember from medical school that may clue you into the diagnosis. On physical examination, obviously, we want to make sure that there is no peritonitis. Sending stool for fecal leukocytes or open parasites or any of one of the other stool and serological studies, I think, are critically important, as well as making a determination about imaging and endoscopy. If the patient is very sick and has peritonitis on examination and they're hemodynamically unstable, you don't need to get a CAT scan. You know what to be able to do. Similarly, is there something endoscopically that you're going to be able to take a look for and then make a determination whether or not you're going to have surgery? Always go through the different etiologies. And again, in this type of a situation, the differential diagnosis is very wide. Everything from, think about viral like CMV to fungal and immunosuppressed, or even parasitic if they were camping and may have giardia or traveling, and then of course bacterial with it. And then you go down, no matter if you're going to go to the operating room or not, you have to have supportive care. Think about the role of antivirals or antimicrobials, and then ultimately surgery. So there's some things that stick out more than others in terms of ominous signs and indications for surgery. Obviously, you go to the examination, you can see each and one of those there, but don't forget about the fact that a patient's got low urine output, they're having altered mental status. This is late in the game, and you want to get to this well in front of that. Also, what is their white count doing? What is their CRP doing? What is, some of the other monitors that you might get on your laboratory studies? And then you're looking for things such as DIC or progressive organ dysfunction. Again, a late stage, we want to get ahead of it well before then. And a simple plain film, although we don't get them as much anymore, might be all that you need to be able to see the dilated colon, free air, and you're going to go off to the operating room. For sure, you want to get surgery involved early. We will get involved early in these particular patients and then make a determination whether we need to offload some of their other organ systems being put on a mechanical ventilator, or is it somebody need to rush to the operating room? But do these benefits carry over into the emergent setting? So think about a colectomy in a lot of different settings. And in these cases, we're dealing with an emergent colectomy. So, should you be able to put these patients together? Do you do a laparoscopic versus open? A nice study about 10 years old right now, but really took a look at a little bit more robust patient out there. Laparoscopic group had lower comorbidities. It did take longer, but shorter length of stay and similar morbidity and mortality. I try to tell people all along that, hopefully that the operation itself, no matter what the surgical approach is the same. And as such, you may still need, or you still may be able to retain some of the benefits with a minimally invasive approach as doing it open. Here in this particular case, the authors realized and said less postoperative morbidity and mortality rates compared to those, and it really reduces the length of hospital stay as well as postoperative other issues such as pain. There's other ones that show that, that it might be actually doing better. And this goes for, again, total abdominal colectomy, a total proctocolectomy, or total anastomosis. And what we looked in this one was inflammatory bowel disease. I think it's important to understand that in this case, we're talking about those type of operations that are in the emergent setting when they go wrong. And in that case, oftentimes you're not going to be able to do a partial colectomy, or you're not going to do a pouch. You're not going to do a total proctocolectomy. It's oftentimes you're just doing a total abdominal colectomy alone. When we looked at a lot of these patients, you'll see 7% of them were emergent. And we looked at multivariate regression analysis that, again, the increased postoperative complications, decreased complication rate, decreased mortality. When you think about all of these different ones, it does favor overall laparoscopy. You might also say to yourself, well, can I just stick a scope in and convert if needed? And the rally situation is, yes, you can do that, but it's important to understand that, and this is a nice study, all elective particular cases, but still conversion was associated with higher leaks, wound infection, ileus obstruction, and overall urinary tract infection. Another study out there that took a look and said that, again, about 17% of these patients were urgent overall. And you can see here at the bottom that when you talk about those patients that were converted, that conversion rate kind of hangs similar. You will notice that doesn't matter if it's for pain, for bleeding, for inexperience, or other things that you might find. In general, that conversion rate is anywhere from 15 to 20%. So in my mind, when you get any one of these consultations, you have to say to yourself, if it's inflammatory, if it's infectious, if it's something that is like an IBD related patient, if you have a need for urgent colectomy, resuscitate that patient, identify and say, is there a contraindication, whether it be you or the patient or the system or whatever it is, to performing a minimally invasive procedure. If it's not, put a scope in and see how they do, and then ultimately make a determination of what you can accomplish, whether it's mobilization only and making a smaller incision, diverting them, or doing a full-blown resection, or do you need to convert? Again, the other thing that I wanted to touch base on is, again, with a very wide topic, is C. diff. This is something that you might get called on a lot. Patient with C. diff, they're not doing well, and all of a sudden they take a turn for the worse. So when you look at fulminant toxic colitis, again, lower percentage, about 1 to 3%. In many cases, they present with wide distension, pronounced ileus. They may not have diarrhea at all. So you may be thinking C. diff with diarrhea, but because they get fulminant colitis, they could get a persistent ileus. Oftentimes, they have peritonitis or severe abdominal pain. The interesting thing about C. diff when it's raging is that their white blood cell count can be greater than 40,000. It goes way up, and they get a dramatic left shift with these. They can get hyperpyrexia with temperatures over 103, 104, and then oftentimes they're malnourished and they have hypoalbuminemia. So in critically ill patients, like I said, you may not have all the ability to do some of the oral agents. So when we talk about metronidazole IV or vancomycin or enemas or fecal transplant, some of the particular hospitals that you may be working at may not have fecal transplant, and you have to do something else. Understand that you have to say to yourself, am I dealing towards things that go with binding the toxin, or am I dealing with something that's going to go against the bacteria? Because you can use some of these different mechanisms of action to go hand in hand with how we teach these particular patients. There is again, a case fatality rate in any patient with C. diff. You can see slowly creeping up, 7.8%, 9.3%, and continues to go up and up, especially as we have some of the more virulent forms of this. So surgical therapy for these particular patients classically is an abdominal colectomy. And you can see that the abdominal colectomy rate increased, about tripled over the time period in this particular study. But unfortunately, mortality stayed the same, and it is a higher mortality than what we would want to be able to deal with. And again, when you take a look at a lot of different studies, it's hovering right around 50%. So when you think about these patients and you make the decision to go to the operating room, understand that you need to continue to follow these patients because you're not out of the water with those particular individuals. So some recent clinical practice guidelines from the American Society of Colorectal Surgeons published just this year. Again, surgical therapy for C. diff should typically be reserved for patients with colonic perforation or severe colitis who do not approve with medical therapy. Now, here's the crutch with this. When you see a patient with C. diff, you don't want to wait until they are too sick, right? You want to be able to get in front of it and not take them as you, if you will, on the down part of their Starling curve. You want to be able to say to yourself, I don't want to take them too early and allow them to have the ability to have the medicine give a shot. But at the same stretch, I want to see if I can get them through and they may not need an operation alone, keeping some of those numbers in place. So subtotal colectomy with an end ileostomy is typically the operative procedure recommended for severe, complicated, or fulminant C. diff colitis. And again, as I said before, whether it's bad C. diff, whether it's bad CMV colitis, whether it's bad UC or bad Crohn's colitis, all of these different colities in the emergency setting, the default operation should be, in general, typically a subtotal colectomy with end ileostomy, and make a determination if you have a Hartmann's pouch or if you're going to be able to bring up a mucus fistula up to the anterior abdominal wall. There's been a lot of information through the years, or a lot of interest in doing something less than the classic diverting loop ileostomy with irrigation. You have to say to yourself, is what I'm dealing with warranted in that patient? Do I have the right diagnosis? Is this really C. diff that I'm dealing with? And you can see what in this particular imaging, what this looks like right here. It all came out of Pittsburgh with Zuckerbraun's group, a small series, Annals of Surgery paper. And again, you can see 42 patients. They did a historical control. As he followed these patients out, the vast majority of them never required a colectomy. And the good news is that the vast majority of them ultimately had their ileostomy closed within 6 months, compared to a much smaller rate, 1 in 5 with the historical control. Now, some of the differences between morbidities versus historical control, there's no question. If you take somebody for a colectomy, or you can do a lesser operation, oftentimes, if that is working right, you're going to have lesser morbidity associated with it, no matter how you look, surgical site infection, urinary tract infection, or down the board, to see that hopefully it's associated with better outcomes. Now, the problem here is that as time has gone on, there has not been a groundswell of information with that. And again, in the last ASCARS guidelines that we published, when you took a look at the literature, this is a weak recommendation on very low quality evidence, what we rate as a 2C. So again, it may be a treatment, it may be an alternative, but there's just not a whole lot there to be able to support it. And again, there's a recent meta-analysis that's out there that would suggest that, again, it's hard to be able to see because historical controls have varied levels of perioperative care. A lot of these don't have few details to ensure they were appropriately and maximally treated. And again, I go back to what I said before, that these results of the DLI and the antegrade irrigation have not been replicated to date in large-scale trials. So when you're specifically talking about fulminant colitis for C. diff, yes, diverting loop ileostomy and lavage is out there, but in my opinion, still remains unproven. There is some data that is out there, and you'll have some people who have a great experience with it. I simply can't provide you high-level quality data that suggests it's any better in many ways of abdominal colectomy. So in general, the total abdominal colectomy with endoileostomy is still the most common operation.